So hello and welcome to Conversations with Esther this evening, today, the 25th October 2023. We are excited to be here to discuss a topic that is very crucial, and in this month of October that we all know is a month of Breast Cancer Awareness Month. Now, our topic today is on breast cancer prevention, diagnosis and treatment. And we have Dr. Harish in the house. Hi, Dr. Harish, how are you?
Hi Esther, I'm fine. Hope you
Good.
do.
So we'll go straight to begin the session. I will request Richard Magoma to pray for us. Richard.
Good evening, ladies and gentlemen. Thank you very much, Esther. Thank you very much, Dr. Harish, for allowing us to use your intellect and wisdom so that we can prevent a lot of costly mistakes. Let's pray. Our dear loving Master in heaven, we thank you very much for this wonderful opportunity that you have given unto us so that we can learn. Because as you say, where there is no vision, people perish. If we do not have the knowledge, if we do not have the data, if we do not have the understanding, we will end up causing a lot of harm to ourselves. We thank those attendees who have come to listen so that we can be able to exchange experiences, we can be able to exchange knowledge so that we can become more powerful in taking care of our health. For we pray this, trusting in the holy name of our Lord Jesus Christ.
Amen. Amen.
Thank you very much, Esther. Thank you very much, Dr. Harish. Thank you very much for those who are attending.
Thank you, Coach Richie. Thank you. Thank you. I want to go into sharing on Conversations with Esther briefly. For those that may also be joining us for the first time, just a brief of who we are, and then we can go straight in. This is who we are. Conversations with Esther is an impact-driven media platform that informs, educates, and rebuilds mindsets to ignite ethical practices within organizations and the community. Conversations with Esther provides a professional safe space, speaking to matters affecting the workplace, social circles, and overall mental wellness. Now, as we talk on that, I know, Dr. as you speak to the cancer side, it affects obviously the mental wellness and of the people, and especially also the caregivers. So we'll have a look at that maybe. Guided by our three values, integrity, excellence, and impact, Conversations with Esther envisions a world transformed by candid conversations, respectable relationships, and the goodwill to make every effort count. Now, I encourage you to subscribe to our YouTube channel so that you're able to watch the previous episodes, and that you also get alerts when we are live. Like now we are live on YouTube. Conversations with Esther, that's on YouTube. You can also follow me on LinkedIn, Esther Katiba. You can go to our Instagram, Conversations with Esther. Now, this is our community. We are building our own network now so that we're able to also update you on the sessions that we have, upcoming sessions. We know we send a lot of this information in different platforms, but when we have our own community and our own platform, we'll be able to just send one message and our people and our followers will get that. So you could take a minute and just scan that QR code and join our community. Then you will be able to get the links, you'll be able to get updates when we have sessions like this and when we have events. We do hold a lot of events that speak to mental wellness, speak to your workplace, speak to HR issues, and speak to different issues. So today we have Dr. Harish Nagraj. Breast cancer prevention, diagnosis, and treatment. I don't want to act like a professional in this, Dr. Harish. I want to be very careful and I want to give you the time, but I want to read out some quotes that I found a bit interesting, because I know in the room we have caregivers, we also have cancer survivors, and we have different people, HR professionals that are also on board here, getting to learn, and different family members and friends. Never be ashamed of a scar. It simply means you are stronger than whatever tried to hurt you. Everyone has scars, whether you can see them or not. Wear yours with pride. The second one says, feed your faith and your fears will starve to death. And the final one says, whatever you do, hold on to hope. The tiniest thread will twist into an unbreakable cord. Let hope anchor you in the possibility that this is not the end of your story, that change will bring you to peaceful shores. So that is what we will say. As you also follow us, I want to introduce Daktari. As I stop presenting this one, let me just stop the share so that we are on the same page. And I introduce Daktari. Dr. Harish Nagaraj has Masters in Diagnostic Radiology from the University of Nairobi, Kenya. He received, Daktari, is this, we call it PET. Is it PET or PET? You will tell us more. Allow me to call it PET CT training and fellowship in nuclear medicine at Bangalore. The Kenyans say Bangalore. I have studied in India, so I know it's Bangalore. Institute of Oncology, India. Additionally, Dr. Harish has a master's in oncologic imaging from University of Pisa. He is highly skilled in the interpretation of CT, PET, CT, and ultrasound guided non-vascular intervention. His key area of interest and expertise are early diagnosis of cancer by molecular imaging, and there are no what, Doctor? Theranostics.
Theranostics,
yes. Yeah, good. He is an active member of various radiology and oncology societies with a presentation and papers, both national and international, to his credit. And I'm aware that we have a lot of people also joining us from India and different places, courtesy of Daktari. I am also aware that we could possibly be having a dignified person and dignified people on our call, including the Director General. Daktari, you know who I mean, Ketel, James Ketel, hopefully. So karibuni sana, Daktari. Over to you. And please, our listeners, keep your questions coming on the chat. I will leave the stage for Daktari so that we can learn and learn and learn. Karibu sana, Daktari.
Thank you, Esther, for that kind introduction. Allow me to share the slides, please. My slides are visible?
Yes, yes, we can see.
Okay, welcome all today's presentation. So as Esther introduced me, I'm Dr. Harish Nagaraj. I'm currently working as a consultant and HOD nuclear medicine and PET-CT at Kenyatta University Teaching Referral and Research Hospital. So let's start talking about cancer burden that is within Kenya and also globally. So if you look at globally, I'm following the Globocan index, which is latest statistical representation of the cancer incidence as well as mortality. If you look at it, it is ranked top cancer in incidence as well as in mortality. That is comes within the top 5. And 2.2 million cases, mostly the new cases are diagnosed globally. And among that, it stands as 5th in terms of mortality, with almost 6.9% of all the cancer deaths. So when we are comparing that to Kenya, it is leading in overall cancer incidence. For an example, if you look at women who suffer with cancer disease, the top two are cervical cancer and breast cancer. But when it comes to incidence, it's the breast cancer which supersedes the cervical cancer, and it changes opposite for the mortality. And the data from 2018, it shows that there were 5,985 cases which were diagnosed. And if you look at 2020, there is a bit of increase in number of cancer diagnosis. We can attribute this to a better diagnosis and also a screening program which is put by government, and also the awareness created among the population in the country and the region. So in Kenya, it is the second leading cause of cancer death among women. That is with 3,211 deaths which occurred in 2020 when compared to 2,553 in 2018. So there is both increase in the number of diagnosed cases as well as the related mortality. This is the global statistics I was mentioning earlier. If you look at the pie chart here, uh, you can see that the breast cancer, among all the cancers, it is 16% is the topmost cancer, the number one. And it is just behind when all the cancers which are combined together, which goes up to 49%. But the top two cancers still remains breast, and then followed by cervix. And number of new cases, as I told earlier, in 2020, if you look at the breast, it's taking a good share of the pie chart here, around 25%, followed by cervical cancer. And you're comparing the incidence and mortality and also prevalence of cancer site. If I have just made a data to show that five topmost cancers within the country, breast stands first. And you see the incidence rate, it is rank 1, whereas in the mortality, that is deaths, it is number 2, the opposite to what cervix is. Cervix usually is followed after breast in terms of diagnosis, and in terms of death, because of its widespread nature of spread to the distant sites, it is ranked 1 in terms of death. The same further to show a good comparison, saying that the incidence looking at breast, it's more in female. In men, as we all know, it's prostate. But for our topic of interest today is breast cancer, so it is followed by cervix. So in terms of mortality here, it is slightly better when compared to cervix, because that overall percentage of diagnosis is 41%, and it's slightly behind 50%. I mean, mortality is slightly below 50%, whereas in terms of cervix uteri, it's quite significant. What is breast cancer? I need to make general population understand something very basic. So we have, as we know, we all have normal cells in the body that have three major characteristics. So usually the normal cells should die after certain duration of time, like every other thing comes with an expiry. Yeah. So the normal cells that do not have a capability to invade other tissues. So it doesn't change its type. It remains as it is and dies in speculated time. Then it also cannot spread to the other organs. These are three major characteristics of normal cells. But overall in oncology, or in basically in cancer, the cells do not follow these rules. Okay. So as we are talking about breast cancer, we need to know two main cancer types in the breast. That is what we call as ductal carcinoma, or IDC, or lobular carcinoma. So I'll explain you with this one with the picture, the next slide, so that you can understand it better. The female breast is made up of mainly ducts, lobules, and stroma. So if you look at the diagram here, there are ducts, yeah. Those ducts are the ones which carries milk to the nipple, and there are lobules, which are milk-producing glands. And also there's stroma, which consists of fatty tissue and connective tissue surrounding the ducts, lobules, and blood vessels. So as I mentioned in the previous slide, the main two sites of the cancer which begins the breast are from duct followed by lobules. What causes cancer? Until today, we are not very certain that this is a specific reason why people get cancer as a disease. We can always speculate that this has caused, but overall major studies, whatever is available as of today, we can only comment that there are certain risk factors which is responsible or which actually accelerates someone getting cancer than compared to the other uh, individual. So there are two types of risk factors. One is modifiable and non-modifiable, not modifiable. So I'll explain you in detail. Non-modifiable risk factors, as you know, once you're aging, aging is something which is continuous and you can't change that, yeah. And also sex and anatomy by virtue you cannot change, and race the same, and family history, especially if you have a very close relative who had a history of cancer, you can't change the history the same. So look at the risk factors in a bit detail. About 5 to 10% of breast cancer cases are thought to be hereditary, caused by genetic changes, that is mutations, inherited from a parent. So the most common inherited mutations are what we call BRCA1 and BRCA2, the most common cause of hereditary breast cancers. These are the ones. And if you can remember, there's famous actress Angelina Jolie. She was also positive for these two genetic mutations, and she underwent bilateral mastectomy. If someone doesn't know that. So continuing with risk factors, as I was talking earlier, family history is something which we cannot change. So women who have a close blood relative with disease have a higher risk of developing cancer. Also, people keep asking me that is it a must that someone who had like close, like first grade relative, that they also should have breast cancer? It's not like that, but definitely the risk increases like fivefold higher. And again, personal history of breast cancer. A woman with cancer in one breast has increased risk of developing cancer in other breast or another part of the same breast. So what we call it as recurrence, disease recurrence. So I have seen many cases in my experience that patients who had a complete remission, they didn't have any symptoms at all. But after a few years of time, who are lost on follow-up, and due to the continuous exposure to hormones and other kind of risk factors, they end up getting recurrence. Sometimes it is still under control, and other times is usually stage 4 disease, which is very difficult to treat. So we can also get breast cancer from certain risk factors, that is getting radiation, chest radiation, and post-menopausal hormonal therapy and recent use of hormonal contraceptives. To go a bit detail in that, for example, if a patient had, for example, thyroid cancer in early stage, so the treatment modality for that could be high dose radiation. We call it as external beam radiation therapy, and that exposes radiation to the breast tissue. Breast is one of the radiation sensitive tissue. So here, the amount of radiation received could later turn into a breast cancer by itself, secondary to the radiation received for some other cancer. And what happens in post-menopausal hormonal therapy? Basically, the high circulating hormones, mainly estrogen, is responsible for developing cancers of that sort. And recent use of hormonal contraceptives. So we actually discourage as doctors that it is not good for someone to be taking oral contraceptive pills for longer duration, again because of high circulating hormones, which will be a risk factor by itself for developing breast cancer. So race, African American women are more likely to die of this cancer and also been diagnosed. So none of us know what is the exact cause of this, but how we came to this conclusion is of course because of the studies conducted worldwide and the data available. And dense breast tissue also is a risk factor because women with dense breast tissue, that means there's more gland as opposed to fatty tissue. So the more denser the breast tissue is, also has a chance of being missed on mammogram when we are doing screening or even diagnostic imaging. So they also have a higher risk of developing breast cancer. Not having children or having them very late in their in their life, that is after age of 30, it also puts women at slightly higher risk. And more menstrual cycles, that is slightly higher risk if women started menstruation early and or went through late menopause. It's also a risk factor. Not breastfeeding. Some studies show that the breastfeeding may slightly lower breast cancer. It actually has an indirect effect on the menstrual cycles and circulating hormones. That is because usually when someone is breastfeeding, what we have is lactational amenorrhea. So when you're breastfeeding, you don't get your periods. So the more you breastfeed, you're putting the periods, you're postponing it, and the same way also the circulating hormones. So this also has an impact on breast cancer. Physical activity, more activity lowers risk, and overweight is directly involved in as a major risk factor. And I can explain you why, because usually reproductive age, that is before attaining menopause, uh, the estrogen is usually secreted by your ovaries. So after ovaries, it's mostly your fatty tissues. So being overweight, that means you have more fatty tissues in you, and you still have more hormones, that is estrogen. Now it actually increases the risk of getting to a breast cancer. So maintaining a normal weight and being active physically actually lowers the risk. So that is the idea behind it. And also alcohol use, it's clearly linked to increased risk, and occasional alcohol usage or in moderation is not a problem as such. But however, now when you're taking a lot of alcohol, again it makes the estrogen to be in circulation and is linked directly to the breast cancer or any kind of cancer. So going to talk about screening now. So what is screening? A screening test is done to detect potential health disorder or diseases in people who do not have any symptoms of disease. So basically, we start testing people randomly uh, to a certain population, and we have a we there are some data available showing that this is a particular age group we're going to target, and we might find some patients who might have been affected in an early stage so that the treatment also becomes easy. So that's the main idea about screening. And it also reduces the risk of the disease, and also we can treat it effectively. Like sometimes people ask me, like, doctor, is it curable completely? Yeah, most of the cancers, when it's diagnosed in early stage, definitely it has complete cure, and you don't need to worry that it's gonna kill you sometime soon. So the key is to get it diagnosed at a pretty early stage so that the treatment is quite effective, and it's definitely. So here I'm presenting National Cancer Screening Guidelines, which was released by Ministry of Health Kenya recently. So if you look at the three columns, that is, which shows age group recommendation and time intervals, you can look at the earliest age we are starting is 25 to 34. That is now for someone who has very high risk, like someone who had a first degree relative who had cancer, and also there have certain risk factor which makes them to be under surveillance for some time. So if you look at 25 to 34 years, we don't recommend mammogram because mammogram comes with a radiation, and that is still too early for patients to be radiated. So what we call CBE is a clinical breast examination. We recommend them to be done every 3 years. Probably we can use either year 1 to 3, depending on the individual. But probably having it once in a year, and not self, but probably by a experienced medical practitioner might help. And the next age group, that is 35 to 39 years, we complement the uh, clinical breast examination with sonomammography, what we call as ultrasound also, because even that age group, the breast is quite glandular and dense, and mammography won't be that helpful. But combining or supplementing with ultrasound makes it quite easy to detect some lesions which were not seen on mammography. So the next age group, that is between 40 to 55 years, now there is some transition of the breast tissues where the glandular tissue is being replaced by fatty tissue, and that is the reason they recommend mammography from this age group. And now they made it mandatory that it should be annual, so that you don't delay it further, and there's high chances of getting uh, diagnosed with breast cancer. So this is basically made that annual interval scans to not miss out, on developing breast cancer. So after 55 years, that is 56 to 74, again it's clinical breast examination plus mammography. But now the risk, actually, if you look at the interval scans, it's now 2 years, every 2 years. Why is that? Because after 56 year, slightly the rate of the breast cancer in an individual starts dropping slightly in the other age group compared to other age group. So that is the reason now they're saying that it can be done once in 2 years. And now at the last age group, 75 years and older, you consider individuals' health factors and women's preference to continue screening. For some of them, after 75 years is almost like maybe less than 5%. So the chances of them getting breast cancer is highly unlikely. And that is the reason that we don't give them any significant or definitive interval time to be scanned. So why we are scanning for breast cancer? Again, as I told earlier in my previous slides, cancers found during screening exams are likely to be very small and still confined to breast, meaning most of the patients are symptomatic, the screening population. So it's much easier to target the lesion and treat it. The size of a breast cancer and how far it has spread are important factors in predicting the prognosis. So in earlier slide, when Esther was introducing me, she was asking me about the PET scan. So PET scan here becomes useful, especially when there's confirmation of a disease. And now if you're suspecting that the disease might have spread to other parts, that is when we use that modality to confirm, what we call it as distance staging. So distance staging, if the patients already have a spread of cancer, what we call a stage 4, then the prognosis becomes worse. So that is the reason behind doing a proper stage. So how do we do clinical breast examination? So there are like 4 methods. People can use their own depending on their how they're comfortable. So the radial method is, if you look at here, it's like spokes. So you can start in the center and try going on each directions to see if there's anything palpable here. And there's also called a spiral mode. Again, you start from center, but now you do a circular motion. Here, what we are showing is an anti-clock motion, but you can still, I mean, the idea is to just go circular from in to out, so that if you find anything suspicious, then it's caution. So then there's also called as vertical method. You are going from down to up and up to down. And you also see a strategic place with nipple and armpits, where you can see if there's any suspicious nodes or swelling, which is most of the time if it's painless, and then if there's any kind of discharge from nipple, these are the usual signs that we need to be careful of. So mammogram, we were talking about, this is mammogram equipment, and this is how it is usually done. They take actually three views, one in the from side by side, and also from top to bottom. If you look at the patient here, she's standing here. There are some transparent plates here which compress, what we call as compressors. It compresses the breast tissue here, and where this is the X-ray tube where the radiation hits, and then there is a receiver here which collects the information. And once the information is collected within the computer, the image is formed, and the clinician interprets the image. So this is an actual mammogram image, whereby you can see this is a breast tissue, and most of it is as a fatty tissue. That's why you're not seeing anything like very white. The more dense the breast is, it becomes white. So in the background of the fatty breast tissue, you see something very white here. It's some irregular or speculated borders. So this is what is breast cancer there. So in terms of localized disease, this is very much within one quadrant, and such kind of cancer have a very good cure, because this can be excised clinically with a very good prognosis, and follow-up of 1 year or maximum 2 years should be good enough. So besides mammogram, we can also use ultrasound, which I already showed you, especially if the patient is younger, and MRI for much complicated cases or high-risk patients, whereby both the basic conventional imaging modalities are indeterminate, and you're not able to make a confident diagnosis. That is when we use MRI. And once the disease is confirmed, and if you're suspecting metastasis, that is when now you'll go for PET-CT scans. So how do we prevent breast cancer? So basically, if you reduce the risk factors, or if you concentrate on the modifiable risk factors, that itself is a good step in preventing certain cancers, and in our case now breast cancer. So you need to set yourself some goals, and stay healthy and maintaining a proper weight, be physically active, and limit alcohol use. Some women can also think about things which are in their control, example breastfeeding, because we know at this particular age and time we can't expect mothers to be feeding the whole 1 year. But if you're not doing exclusive, at least you can do maybe twice in the morning before going to work and also coming back from work. That really helps actually in this kind of scenarios. And also try avoiding hormonal therapy to deal with symptoms of menopause. So unless it's not too difficult, uh, discuss with your clinicians, and see if there's any good alternative without using any hormonal therapy for the same. So going much deeper into signs and symptoms of breast cancer, what to look out for. Basically, you'll start looking for skin changes in texture, but unfortunately, these all signs and symptoms which are put here in the slide usually comes in later stage. That is the biggest challenge with cancer, because most of the time when the cancer is detected, already there are some changes within the body. So, but also sometimes if you're very keen and know your body well, you can definitely pick some changes quite early. So looking at first image, like you can see there is some changes in the skin texture. There could be any kind of dimpling of the nipple or the skin surrounding it, and lumps when we are doing a clinical breast examination. Sometimes because of the high, I mean, in the reproductive age, when the breasts are very dense, you can also feel the normal glandular tissue to be like a lump. So I do know people, one of few of my patients, they get paranoid and worried, and for them we usually do both clinical examination and also we confirm the same with ultrasound scan, and then we reassure them that this is just a normal glance and no lump. And as I told earlier, you could look for some discharge in the nipple, and most of the time is it's painless, and that is a bit of a giveaway at that time. And also look for nipple inversion and changes in direction. So when you look for the symmetricity, one nipple will be looking slightly different from the other, and it kind of looks flattened. And also look for the swelling around the armpit, and feel constant pain in your breast or armpit. So this pain is a bit vague, and it is not specific, or it's not specific for symptoms and signs for breast cancer. The pain can happen in any kind of illness. For example, if there's a inflammation of breast tissue, what we call as mastitis, secondary to infection or breastfeeding, this can also give pain and swelling. So this is not specific for cancer signs and symptoms. And you can look for change in shape, size and shape. That is, look for symmetricity. When it's not symmetric, then there is some kind of issue which need to be addressed, or at least meet a clinician so that they know what exactly is happening. And also look for rash or crusting of the nipple or surrounding area. So this is something again a bit advanced, where you're going to see such kind of changes, and not in a very early stage. So this is again an illustration how one can expect and changes, which I was explaining in the previous slide. So once we are diagnosed and we know the definitive staging, whether it is early stage or it's advanced stage, the treatment comes in different options. So as I was telling earlier, if it's stage 2, then stage 1 and 2, like you can have complete excision, and followed by follow-up imaging. At certain instances, when the margins, when you're doing a surgery and the margins are positive, oncologists like giving probably an extra radiation or neoadjuvant chemotherapy. So targeted therapy is another kind of therapy which is coming in good time. This is basically to boost your immune. What in other ways it's called as immune therapy. And radiation, we all know radiation therapy. We can be giving the boosters. That is, you try to kill the cells through radiation. And chemotherapy, it's basically a systemic therapy. And once you know the cancer is spread to different organisms, you cannot do surgery at all places or even give radiation. That is when now oncologists decide to do chemotherapy. And hormonal therapy, if it's also a part of therapy, but now it is not standalone. Most of the time, if you look at the fully treated cancers, they put on hormonal therapy as a maintenance dose, but still patients will be on follow-up. So these are the treatment options available. And we are stressing that for the population of Kenya and its region, that there is definitely a good chance of cure if detected in early stages. And for the same, Ministry of Health has now made good use of chemotherapy services. And apart from the national referral, that is level 6 hospitals, chemotherapy services are also made available in regional level 5 facilities. To name few: Nakuru, Mombasa, Garissa, Kisumu, Embu, Meru, Bomet, Kakamega, Machakos, and Nyeri. So if you're from that area and if unfortunately your relative or someone has stage 4 cancer and they require chemotherapy, you can avail those services at those mentioned counties. So that's my presentation. That's the last slide, and that's my email ID. So if you have any specific questions which you can't remember now, we can always reach out to me on that email. Thank you so much.
Wow. You know, when we get to conversations on cancer, it becomes, unfortunately, like a moment of silence. You know, I listened to you, Daktari, and when you started about chest radiation, contraceptives, early menstruation, not breastfeeding, not having children or having them late, overweight, hormonal therapy for menopause. I mean, it's it looks like it's at every stage, you know. You can get it anytime. I don't know. You want to respond to that before I go to the questions, because
Yeah,
and
yeah.
the
I mean,
hospitals are also used to chest radiation, Daktari. A small
yeah,
thing, you're coughing, they take you to a machine.
that's very true actually. But now again, what we call as ALARA principle, as in terms of radiation, we keep it as low as possible. So meaning if someone has a chest X-ray, that doesn't mean that he has a high radiation which can actually predispose someone to get cancer. So having a chest X-ray once in an off time, it's not something very serious. But you raised a very good point. I mean, since we have resources, we should not be misusing it. I mean, you have to do a proper clinical evaluation first and make sure that this patient, whether he requires probably a CT scan or X-ray, it all depends on the proper clinical evaluation. And based on the findings, that is when we decide whether this person need to be having any kind of radiation of that form. But yeah, I had seen in my personal experience, I had seen at least a couple of patients who had treated for thyroid cancer, and the age was I think around 13 or 15 years. The patient had was irradiated for the thyroid. So when they came to us, there was no disease in the thyroid; it was completely gone. Unfortunately, with no kind of risk factor or whatever, the patient had breast cancer that was detected in age of 36. So it has taken almost 15 years for the patient to develop from that radiation to have a new cancer. That is the second primary. So what you said is absolutely correct, and we do get such kind of situation, but now we need to be a bit rational in using our resources.
Yeah, and I'm seeing some questions here. Maybe before I go to the question, speak to contraceptives, because this is very common with women, and most of them will just prescribe that for themselves or just use what their friend is using. So what should people do? Because it looks like, and I've listened to many doctors that say this is a big risk. So you're on mute, Daktari. Sorry.
Yeah, again, it's a matter of balancing. And now, even food or whatever you're taking in excess, which is not needed, becomes poisonous to us. And look at hormones. When you're talking about OCP, oral contraceptive pills, what is it basically? It's hormones. They're making imbalance of hormones, either like to have the pregnant to be miscarried, you'll make an imbalance. Though I don't prescribe that medication, but as a doctor, I can tell that this is a direct kind of risk factor if someone is using it for longer period of time. But I think there are other ways of contraceptive methods which are very safe to both the partners. So I think we should start implementing and using those while it doesn't affect both of them. And definitely, I think reproductive medicine specialist and gynecologist in the country, we have very good gynecologists. So people should make use of it. And I would suggest that Google Doctor is not very advisable from my experience.
Good. Florence asks, how do I reduce the growth of keloids on my scar?
They're asking about keloids.
Yes, how to reduce the growth of the keloids on the scar.
So first, I mean, there are different ways of treating that. You can as well do radiation or give some steroids. Usually, you can give steroids. You can inject the steroids on a timely basis and do a follow-up. The idea is just to make it shrink because now once someone is diagnosed with keloids, putting a knife again will cause it to recur again.
Wait, Daktari, sorry, for the benefit of those who are on the call and wondering and Googling, you told us this Google person, what are keloids? I'm just
Keloids is
asking for.
basically it's overgranulation. You know, when you have a normal cut, our skin heals normally with a very minimal scar. Okay, so in keloids, what it does is like there is excessive granulation tissues. It itself it looks very shiny on appearance, and it looks very unpleasing cosmetically, and especially if it comes on the places where we expose. So this is what actually brings patients for a treatment of keloids. Uh, that's what like I know for a fact that keloids, if it's not very excessive, they can be given a very small dose of steroids. And also, if it's quite big and if it's troublesome, they can go for surgery, which is followed by external beam radiation. So I think if the keloid is very big, you need to check with the clinicians.
Good. Lucy asks, is it common for men to get breast cancer?
I wouldn't say common, but we have to realize that men also have similar kind of tissue in the body, and there are chances of like 0.5 to 1% to get breast cancer. I do see in my practice that there are men with breast cancer, but they're not quite common. We do see, but it's not common. Yeah.
Good. Florence says again, that was enlightening presentation. Thanks, Daktari. What would be the effect of taking alcohol while on hormonal therapy? And is it normal to have slight pain on the scar?
Which scar is it?
I don't know. Florence, you can unmute if you're okay.
Breast
Yes.
mastectomy. Hello?
Okay, Florence, I don't see a direct relation between taking alcohol and pain in the scar. But when patient is already on hormonal therapy and again having alcohol, which will make the hormones to secrete, is not a great idea to have it.
Good. Thank you. Anyone else with a question? You can unmute. Richard, do you have any questions? And as they unmute, Daktari, surgery for cancer, the common lay person believes that surgery just makes cancer spread. The common, is that true?
Not really. Even some of them think that taking a tissue nyama from that place can also cause the cancer to spread. If the procedures are done in a proper way, of course, nowadays we have very advanced techniques and we have very well qualified professionals here. So I don't see any, I mean, to panic, need for panicking that the surgeries can cause spread of disease. So we usually take, it's like, how they scoop when you're giving an ice cream. They kind of go, they leave some kind of normal tissue so that they completely cover, and that is when I'm sent to the pathology to see that if there was any spread around that region. And especially when the surgeons are not very confident that they removed all the tissues, that is when they with conjunction with the oncologist, they decided to give radiation to that mastectomy bread or lumpectomy, so that whatever the remnant cancer cells there in that operative site, that can be killed with external beam radiation.
Wow. Anyone else with a question? You can unmute. Magoma, you have any question?
No, Esther, I do not have a question. But what I'm seeing is these discussions need to be spread, because so many things predispose us to having this problem. I don't know why people ignore this awareness, and yet every other day we have factors that will cause us to have breast cancer, or somebody we are related to. I don't know what kind of sensitization we need so that everybody becomes a participant in the wellness of everybody. That is probably the challenge I'm seeing. People take these things lightly, yet we can prevent them if we have the information. Like now, the information, if I'm sure if somebody went to Dr. Arish, I don't know what his cost will be getting this information, yet right now we have gotten it at a price of zero by just presence. I think we should have more of these discussions so that people internalize some of those things that cause these problems, especially now the problem we are discussing of breast cancer. Thank you, Dr. Harish, for enlightening us on this problem. Even some of us did not understand biology. I've been able to understand a little bit of it today. At least I've understood what causes the costing, the machinery that is involved. Thank you very much, and God bless you for agreeing to give us knowledge for free. Thank you very much.
Thank you, Richard. Anyone else with as we think through, Dr. Not having children or having them late after 30 years. I'm still stuck on that one. And especially for the book lovers, those who love going to school and studying and in Africa, by the way, there's an interesting conversation, Dr. now that you're from Bangalore and you've been in India, because the conversation there is, if you tell someone in India that you are 23, 25 years, the first thing they ask you, and you're not married, you're late. That was a conversation, and we would feel like they are pushing us.
That is not same now, Esther. That is not same. People are actually evolved, and they have bigger responsibilities. But whatever we are talking now is based on the data available, and also the direct relation with hormones happening. I mean, the reason they're saying to have kids is, again, now you see, we were talking about breastfeeding. That is indirectly saying that to reduce the menstrual cycle, and now keeping the hormones in balance, which actually reduces. So these are all based on the data available to us, and how the studies were done. But if you clearly look at, be it in India or any other place now, with the amount of equal opportunity, equality, and we are seeing women in a very good position, and they are achieving a lot more. And there's no one that someone who's marrying at 23 or 24 these days. That is, you can take it from me directly. I mean, and there are probably maybe from Shagos or but urban women, even that is another interesting study and comparison that if you look at statistics, the breast cancer diagnosis mostly it's in the urban population, whereas cervical cancer it's more from Shagos. So that is also, I mean, definitely there's involvement of papilloma virus, hygiene, and also not vaccination, early exposure to sexual life, and all those things, unprotected sex. These are all contributing. But now you see the urban population are more learned, and they try to avoid this kind of thing. So that is why a study says that cervical cancer is much lesser in the urban population than the Ushagos, and then contrary that the cervical cancer where the patients does, I mean, people don't have enough knowledge suffer from this kind of cancer. So these are all based on studies and the data available.
Wow, and I think we need to bring you back so that we also speak about cervical cancer one of these days. We don't have to be waiting for these dates, that we talk about cancer only in October, and the rest of the year we are ignorant. I think we need to have you back and really speak to different types of cancers, which I think is important. But asante sana. Thank you, Daktari. Thank you for the knowledge. Thank you for the information. And thank you everyone for joining the session. It's 8:06. Asanteni sana. Have a good evening. God bless you. Bye-bye.
Thank you so much, and goodbye to everyone.